Welcome back to my YouTube channel. If you are new to my channel, welcome to MedCode Insight. Hi, I am Nishaba, a certified medical coder. In this video, we will cover another an important topic, skin replacement surgery or grafting of the integumentary system. We will discuss the surgical preparation of the skin graft recipient sites, graft terminologies, and how to use the elimination method to choose the correct code quickly. Let's start our video with the hope of creating a better understanding. Skin replacement surgery involves surgical preparation and topical placement of autograft or skin substitute graft. Surgical preparation for skin replacement surgery describes the initial services related to preparing a clean and viable wound surface for placement of an autograft, flap, skin substitute graft, or for negative pressure wound therapy. For practicing surgical preparation, we must highlight the important key points provided on CPT page number 99, especially for the type of the wound we can't use the surgical preparation codes and how to codes when dealing the multiple wounds on the same day and when to use modifier 59. Let's discuss some important coding guidelines related to surgical preparation codes. Surgical preparation is the final process when preparing a clean wound bed prior to primary or tertiary closure. If a wound will be left to close by secondary intention wound healing, like when a wound that can't be stitched and doctor leave the wound to heal naturally, in these cases, without active intervention, surgical preparation codes are not reported. Surgical preparation codes are based on the location and size of the resultant defect. For multiple wounds, sum the surface area of wounds from all anatomic site data grouped together under the same code descriptor. Surgical preparation involving different groupings of the anatomic site should be reported with modifier 59. Before discussing for autografts, tissue culture autograft, and skin substitute graft, first we will need to know what the grafting procedure is. Grafting is a surgical procedure to move tissue from one side to another on the body or from another creature without bringing its own blood supply with it. In a sense, grafts are replacement parts of our bodies. So, where do they come from? Doctors have a few options. Let's explore some terminologies related to grafts. Here are some key terminologies you should know before coding for grafts. First one is autograft. In autograft, tissue transplanted from one side to another within the same individual. In allograft or homograft, tissue transplanted from one individual to another of the same species. It may be harvested from a cadaver. An isograft describes tissue transplanted between genetically identical individuals, like identical twins. In xenograft, tissue transplanted from a donor of different species, like from animals to humans. Autografts and tissue cultured autograft codes are categorized based on the type of the graft, the location, and the size of the defect. Here is a general overview of how the type of the graft influence graft selection and coding. Pinch graft contain one or more patches of skin. Split thickness autograft contain the epidermis and a portion of the dermis. Full thickness skin graft contain the epidermis and entire dermis. In epidermal autograft, graft contains epidermal layer of the skin. In dermal autograft, graft containing middle section of the skin. In tissue culture skin autograft, skin cells cultured in a lab to grow new skin and then grafted. For practicing autograph or tissue culture autograph, we must highlight the important key points provided on CPT page number 99. Especially the autograph codes include the type of the debridement and under which condition should code it separately, as well as how to code when dealing with multiple wounds. There are some coding guidelines we need to follow while coding for autograft or tissue culture autograft. Autograft or tissue culture autograft involve harvesting and or applying of autologous skin graft. Removal of current graft and or simply cleansing of the wound is included when performed. Autograft codes are based on the type of the autograft, location, and the size of the defect. Sum the surface area of all wounds from the anatomic side grouped under the same code descriptor. Don't sum the wound from different anatomic side grouping. Skin substitute grafts based on location and size of the graft. Types of grafts used for skin substitute grafts are homograft, allograft, or xenograft. There are also some key points for coding skin substitute graft. As provided on CPT page number 99, the coding guidelines for debridement and dealing with multiple wounds are same for both autografts and skin substitute graft. Additionally, it is important to know how to code the supply of skin substitute graft along with skin substitute graft codes. Here are some coding guidelines you need to know while coding for skin substitute grafts. Skin substitute graft include the application of not-graft wound dressing. The removal of the current graft and a simple cleansing of the wound is included when performed. Codes of skin substitute graft based upon the location and the size of the defect. Sum the surface area of all wounds from the anatomic side grouped under the same code descriptor. Do not sum the wounds from different anatomic side grouping. Supply of skin substitute grafts should be reported separately in conjunction with skin substitute graft codes. Now let's focus on an important step, choosing the correct code within a minute. When selecting a code for grafting procedure, we first eliminate the option based on the type of the graft used. It may be autograft or skin substitute graft. In case of autograft, first check the type of the autograft. It may be pinch autograft, split or full thickness, epidermal or dermal or tissue cultured skin autograft. And then select the code based on the location and finally on the size of the defect. For skin substitute graft, it may be homograft, allograft, or xenograft. First check the location and then the size of the defect. Let's understand the guidelines through the practice question to gain a better understanding. Patient presents to the operative suite with the biopsy-proven squamous cell carcinoma of the left ankle. A decision was made to remove the lesion and apply a split thickness skin graft on the site. The lesion was excised as drawn and documented as measuring 2.4 cm with margins. The surgeon harvested a split thickness skin graft from the left thigh, which was matched 1.5 into 1, and then insert into the ankle wound using a skin stapler. Zeroform plaster was then placed on the skin graft using zeroform and nylon, and the lower extremity was wrapped with bulky cast padding and double S wrap. The skin graft donor side was dressed with offsite. The surgeon noted the skin graft measured 9 square centimeter in total. What CPT and ICD 10 cm codes are reported? Option A with the service code 15,100, 11,603 along with modifier 51, C44.729. Option B with the service code 15,100, C44.729. Option C with the service code 15,120, 13,100 along with modifier 51, D22.72. Option D with the service code 15,240, 11,603 along with modifier 51, C44.719. In the given scenario, excision of a squamous cell carcinoma of the left ankle measuring 2.4 cm with margin was performed, followed by coverage with split thickness skin graft measuring a total of 9 square centimeter. In the first step, we will eliminate the option based on the type of the graft used. In the given scenario, a split thickness skin graft was used for coverage. So we will first eliminate option D with the service code 15240, which is for full thickness graft. After eliminating option D, all remaining options have initial code for split thickness skin graft. Since the procedure takes place on the ankle, we will eliminate the option based on the location. Therefore, we will eliminate the option C, which has the code 15120, which is for the split thickness graft at the sites other than the ankle. In the given scenario, excision was performed along with reconstructive closure. The guideline for excision of a malignant lesion state that reconstructive closure should be reported separately. Based on this guideline, we will also eliminate option B. In the option A, code 15100 refer to split thickness skin graft for sites including ankle. Since the lesion is on the ankle, we narrow the code range 11600 to 11606. Given that the lesion measured 2.4 cm, the correct code is 11603. Modifier 51 is appended to 11603, indicate that the additional procedure were performed in the same session. The diagnosis is C44.729 is for squamous cell carcinoma of the skin of the lower limb. So our correct option is option A with the service code 15100, 11603 along with modifier 51 and C44.729. Martha has a non-healing wound on the tip of her nose. After an evaluation by Dr. Martino, a dermatologist Martha is scheduled for a procedure the following week. Dr. Martino documented an autologous split thickness skin graft to the tip of the Martha's nose. A simple debridement of granulated tissue is completed prior to the placement. A split thickness skin graft of 10 square centimeter was placed onto the nose defect and secured with suture. The donor site is examined, which confirms good hemostasis. How would you report this procedure? Option A with the service code 99213 along with modified 25 15050. Option B with the service code 15120 11042 along with modifier 51. Option C with the service code 15277 11042 along with modifier 59. Option D with the service code 15120. In the given scenario, simple debridement was performed prior to the placement of split thickness skin graft measuring 10 square centimeter onto the nasal defect. First, we will eliminate the option A, which has the service code 99213, which is for the evolution and management code. After eliminating option A, we will also eliminate option C based on the type of the graft used. In the given scenario, a split thickness graft was used, which is one of the type of the autograft, while the option C with the service code 15277 refer to the application of skin substitute graft. As in the given scenario, debridement was performed along with the placement of an autograft. According to the guidelines, simple cleansing of the wound is included when performed. Debridement is considered a separate procedure only when gross contamination required prolonged cleansing. Based on this guideline, we will also eliminate option B. And our correct option is option D with the service code 15120. A 16-year-old boy was burned in a fire and transferred to a burn center for definitive treatment. Due to the extent of the patient's burns and the lack of sufficient donor sites, his full thickness burns will be excised and covered with xenograft. After the induction of anesthesia, the excision of the burn scar was undertaken. Attention was first directed to the patient's face, neck, and scalp, where a total of 500 square centimeter had sustained full thickness burns. The scar in this area was excised down to viable tissue and hemostasis was achieved using electrocautery. Attention was then turned to the hands and feet, which had a total of 300 square centimeter of full thickness burns. The scar in this area was also excised down to viable tissues and all involved area were covered with xenograft. Option A with the service code 15,200, 15,201 into 123, 15,002, 15,003. Option B with the service code 15,275, 15,276 into 31, 15,004, 15,005 into 16. Option C with the service code 15,277, 15,278 into 7, 15,004, 15,005 into 7. Option D with the service code 15,130, 15,131 into 7, 15,002, 15,003 into 16. In the given scenario, excision of burn skull or the surgical preparation of full thickness burn covering 500 square centimeter on the face, neck, and scalp, and a total of 300 square centimeter of full thickness burn on the hands and feet is performed, which is covered by xenograft. First, we will eliminate option based on the type of the graft used. In the given scenario, a xenograft was used, so we will first eliminate option A, which has the service code 15,200 for the application of a full thickness graft. We will also eliminate option D with the service code 15,130, which refers to the application of a dermal autograft. After eliminating option A and D, both remaining options are for skin substitute grafts. Since all would described in the scenario fall under the same code descriptor, we will first sum the area of all wounds, which is 800 square centimeter. Code 15,275 covers multiple digits for an area up to 100 square centimeter, while code 15,277 cover multiple digits for an area greater than 100 square centimeter in the patient aged 10 or older, or for 1% of the body area in the children under 10 years. So based on the size of the defect, we will also eliminate option B. Option C reports the skin substitute graft codes. Since all codes fall under the same code description for both types of the graft and surgical preparation, we can add the size together. 500 square centimeter for the face, scalp, and neck, plus 300 square centimeter for the hands and feet. This gives us total size to be covered of 800 square centimeter, coded at 15,277 and 15,278 into 7. For surgical preparation of 800 square centimeter, it will be represented with codes 15,004 and 15,005 into 7. A patient requires skin graft on both of his legs and feet. The left leg required 40 square centimeter full thickness graft, and the right leg required a 40 square centimeter split thickness graft. Both feet required 10 square centimeter full thickness grafts each. The skin was harvested from patient's trunk and buttocks to cover all of the wound. The surgical sites of both legs and feet were prepared on the same day. Which procedure codes best describe this encounter? Option A with the service code 15,002, 15,004, 15,100, 15,220, 15,221 into 3, 15,240. Option B with the service code 15,220, 15,221, 15,240 into modifier 51, 15,100 into modifier 51, 15,004 along with modifier 59, 15,002 along with modifier 59. Option C with the service code 15,240, 15,220, 15,221 into 3, 15,004 along with modifier 59, 15,002 along with modifier 59, 15,040 along with modifier 59. Option D with the service code 15,220, 15,221 into 3 along with modifier 51, 15,240 along with modifier 51, 15,004 along with modifier 51, 15,002 along with modifier 51. In the given scenario, a full thickness graft of 40 square centimeter was performed on the left leg, a split thickness graft of 40 square centimeter on the right leg, full thickness grafts of 10 square centimeter on each foot, and surgical preparation of all sides was done on the same day. In the given scenario, both a split thickness skin graft and a full thickness graft were used for coverage, as mentioned in all provided options. We will eliminate the option based on size. First, we need to determine the size of both types of graft. The full thickness graft for the left leg is 40 square centimeter, represented by the code 15,220 and 15,221, while the graft for both feet is 20 square centimeter, represented by the code 15,240. The split thickness graft for the right leg is 40 square centimeter, represented by the code 15,100. On the base of size, first we will eliminate option A and C with codes 15,220 and 15,221 into 3. We will also eliminate option D based on different wound sizes and modifier used with add-on codes. In the option B, 15,220 and 15,221 for the full thickness graft for the left leg, 15,240 for the full thickness graft on the both feet, and 15,100 for the split thickness graft of the right leg of 40 square centimeter. Modifier 51 is appended to both codes to indicate that additional procedures were performed in the same session. The surgical preparation codes with 59 modifier on the both codes indicate that the multiple wounds are belong to different anatomic site. Thank you for watching. If you have any question or need further clarification, please feel free to write in the comment section. For more detailed guidelines, CPC mock exam related questions and notes, email me at the giving email ID.